Welcome back to Four Eyes, the podcast series that gives you a clear view into the optometry world across Canada and the US. We are your hosts. I'm Dr. Amrit Bilku.
I'm Dr. Deepan Kaur.
Hi, I'm Dr. Ravinder Randhawa.
And I'm Dr. Alex Kuhn.
So this week we have a new drug that's going to be out on the market. It's called Zerviate. It's a new anti-allergy eye drop that is released by Eyevance. It is by prescription only, dosed twice a day. Right now it's only available in the States, not in Canada yet.
Mm-hmm. So this is an active ingredient called cetirizine, 0.24%. And it's actually delivered with common ingredients of glycerin and hydroxypropyl methylcellulose, which are basically the two common ingredients in tear lubricants, so that it provides anti-allergy relief and optimal comfort at the same time.
Which is great because most antihistamine drops are so drying to your eyes.
Yeah.
So this will be really great. I wonder when it's going to come into Canada. I don't think there's any reports of when it's going to come to Canada, but hopefully soon.
Yeah, this will be really exciting if it does come to Canada because cetirizine used as a topical form, this is the first time ever, I think, in 10 years that there's been a new development in an anti-allergy drop. And looking at the list of all the anti-allergy drops that are available in Canada and the US, this is the only one that has cetirizine in there as the main ingredient.
There were clinical trials that were done, and in the clinical trials, it showed rapid relief of itching within 3 minutes, so which is really good.
Yeah, that's really good.
And the itching was relieved for up to 8 hours in those moderate to severe allergic conjunctivitis patients.
8 hours? Holy.
That's a lot.
That's a lot.
And then since this is a prescription drug, it's not over the counter, the company Eyevance is actually offering a copay savings program to patients that you want to prescribe this for. And so you can check out those copay savings at www.myeyesavings.com. They're trying to make it as affordable for patients as possible, especially if your patients have tried other over-the-counter anti-allergy drops before and it's just not doing enough for them.
So in other news, the Lancet Medical Journal came out with a brand new article about retinopathy findings in COVID patients. So in the study, there were 12 patients aged 25 to 69 years old, and they were examined with retinal OCT imaging 11 to 33 days after COVID symptoms began. So what they found was these hyper-reflective lesions at the level of the ganglion cell layer and IPL, and more prominently within the papillomacular bundle in both eyes. And few of these patients also had very subtle cotton wool spots and microhemorrhages along retinal arcades. There was no anterior or posterior inflammations in the patients, and they were pretty much all asymptomatic. So they all had normal visual acuities and normal pupillary reflexes.
So when I was looking into the article, I kind of wanted to see if any of the patients had any difficulty breathing.
Yeah.
And then it did state that all the patients had dyspnea.
Okay.
So which just means difficult or labored breathing. So
okay.
I was kind of wondering if the cotton wool spots or microhemes were potentially caused by them coughing or trying to breathe.
Yeah.
So the article didn't really state anything about that, but that's my 2 cents.
To your 2 cents, Rav. Not your whole $2. Your toonie.
Just
got
that
COVID
cents.
money right now. She can't afford $2.
$2 too much, man. Too much.
But yeah, so these obviously can be easily missed because the patients will not have any symptoms and everything will look pretty much normal. But once you do that OCT, then you might see it. But there hasn't been any findings on they have to do more long-term studies to see how this will affect these patients long-term.
And I'm really interested to see if these findings are going to be stable within the retina for a long time, or if they're going to kind of dissolve and go away, and then 10 years later no one's going to know that they had this, or if it's going to progressively get worse. That would be really interesting to know.
There's probably so many more patients with these findings too, but nobody's looking because they're not symptomatic. So it's like,
And I wonder, honestly, how many optometrists are really accepting patients that are COVID positive too? Like outside of a hospital setting, right? I feel like we're not going to find a lot of ocular findings because every time someone tests positive for COVID or a screening question, most optometrists are probably just turning them away anyways.
or yeah, telling them to stay home until they get better. Yeah.
So I feel like
That's true.
lot of those findings are probably they're gonna go unseen.
Yeah.
The third thing in optometry news this week, Black Eye Care Perspective is promoting a 13% pledge. So Black Eye Care Perspective, if you guys don't know yet, was founded by Dr. Adam Ramsey and Dr. Daryl Glover, and they're initiating a 13% promise in the eye care industry and profession. So this is because the U.S. Census data shows that 13.4% of the U.S. population is African American, but Black doctors or African American doctors only represent a really slim percentage of all the doctors in the U.S.
It says that 1.8% of practicing optometrists are African Americans.
Black Eye Care Perspective wants a 13% promise to basically promote more inclusion of the Black community in the eye care profession and industry. So basically, if you go on their website, blackeyecareperspective.com, you can join the pledge and reach that 13% in your own clinic or your own company or corporation. They're offering assistance and consultations to help companies and even schools to learn what they can do to incorporate more Black students, doctors, teachers, staff members, leaders, and directors in our profession.
Wait, but it doesn't have to be owners either, right? It could just be anyone.
It could be anyone. So basically, anyone can join the pledge. If you're part of a company or a private practice or some sort of corporation, and you work with other people, and you feel like when you take a step back and look around at your place of practice, and you see that there aren't that many, Black Americans or Black Canadians in your profession, then you can sign up and just kind of learn how can you encourage more Black people to join your profession or include them. I think this is a big one for schools that I feel like we can directly relate to, because at ICO, the amount of Black students that were at ICO was very low.
Yeah.
So I think for schools, this is going to be a huge thing. And I hope they actually really help out the schools to try to incorporate more Black students.
Yeah.
Today, I'm really excited because we have my residency mentor and colleague, Dr. Debora Lee, who is an exceptional optometrist and clinical professor at UC Berkeley. She has all the knowledge and many years of experience when it comes to amblyopia, strabismus, binocular vision, you name it. And so we've invited her to come onto Four Eyes to share that info with you guys today. One disclaimer, this interview again is recorded over Zoom, so apologies in advance for any audio lag or any distorted sounds. Dr. Lee, would you like to give us an introduction about yourself?
Sure. So as you mentioned, my name is Dr. Debora Lee. I have been practicing since 2008 when I graduated from Berkeley Optometry. After that, I did a 1-year residency in pediatrics at SUNY, and then started working back at Berkeley Optometry at the Binocular Vision Clinic. So I am there now full time. I teach. I also teach in the clinic as well as in a couple of the didactic courses in the binocular vision labs. I used to work in a community clinic until I decided to pursue my master's of public health. So I actually dropped that second job, continued on to get my MPH. And now I also have 2 little children that basically take up the rest of my time.
Yeah, we wanted to invite you onto Four Eyes today because you know everything and anything about binocular vision, amblyopia, strabismus, vision and learning. And a lot of our listeners and some of us at Four Eyes, work in private practices or corporate practices, and they might not have that much exposure to pediatric patients.
Sure.
So we wanted to do a huge discussion on amblyopia today.
Your introduction is very kind. I wouldn't say I know everything, but I have some years of experience that hopefully you'll find helpful.
More than we do. So that's all that matters.
So just to get things kicked off here, is there an age limit to treating amblyopia?
So that's a great question, because if you had asked that same question maybe 10 years ago, and arguably depending on who you ask, many will say that there is still an age limit. Now, some say that the age limit is age 7, because that is more or less what people think of as the end of the critical period of development. In other words, your visual system is less plastic, and therefore you may not get that much visual acuity recovery or visual function recovery. There's an older paper out that was published out of an ophthalmology journal, I think in the 1980s, that said age 12 was the cutoff, and you may hear that a lot from others, saying that you have to get in all amblyopia treatment before age 12, because after the kid turns 12, there's nothing you can do. I think a lot of the more recent research, both out of PEDIG, which PEDIG stands for the Pediatric Eye Disease Investigators Group, and some more of the recent research is really showing, there's not really an age limit. Certainly kids that are younger will respond faster, so they may not need as much treatment, but it's almost like the sky's the limit. So, these days, at least at Berkeley and many other places I can think of, it's like, well, why not try?
Mhm. So being like kind of in a private practice, so if I get like an amblyopic patient in my chair, what would be the best method of treatment? Like where do I start first?
I think some of the considerations you would need to take into account is, well, what tools do you have available to you?
Yeah.
I'm practicing in an academic institution and in a specialized clinic like the binocular vision clinic. We have so many things. Like we have red-green filters, we have red lens filters, we have polarized filters, we have patches of all types. We offer vision therapies. So we have a lot of things at our disposal. When I practiced in a community clinic with that population, we were really limited to patching or atropine, even though some of the research is showing now that there may be other types of treatments that are equally as promising, if not more. That's still the mainstay. It's still the gold standard. It's what all of the papers are still comparing to. It's also the easiest to do. You either get an eye patch or a Post-it or tape or something to occlude one eye, or 1% atropine has a generic, at least in the US. So it's a really cheap, pharmacological way of treating it. And it's equally as effective. You only have to dose it on the weekends. So that, I think in private practice, those would be the easiest things that you could reach for.
Yeah. What about like binocular amblyopia?
So binocular, that's a good question, because those treatments I just mentioned are really
more like binocular, yeah.
Right, it's really for unilateral amblyopia. If you have bilateral binocular amblyopia, you're really limited to refractive correction. There's not a whole lot more that you can do, especially if the amblyopia is equal.
Yes.
Meaning like maybe it's, again, when I was a community clinic, is a lot of high SIL, right? So it's like bilateral meridional amblyopia, both eyes best corrected 20/40. That was pretty common. The good news is that when you look at the PEDIG studies, at least a quarter of those patients with glasses alone can get to 20/20.
Okay.
And then a vast majority of them can get at least a couple lines better. So 20/40 to maybe 20/25. That's still a good proportion. It's not everybody, but it's good.
Yeah. So say if you start with a glasses prescription for amblyopia, how long should that be done for? Or how long should you do that before considering other treatments like patching?
Oh, totally. So in terms of follow-up, what the PEDIG studies did, and I think what many do now, is following up about every 6 to 8 weeks. Let's say step one is you see the patient, newly diagnosed amblyopia, see them back in 6 to 8 weeks after you prescribe your glasses, measure the VAs, and if they've gotten better, see them back in 6 to 8 weeks, measure again. You're going to keep doing that until you get 2 consecutive visits of the same VA. Because that would signify that there's some type of plateau, and then you would move on to whatever your next treatment is that you want to do, whether it's occlusion or pharmacologic, some type of penalization.
Okay.
Would that follow-up period be the same if you were giving them atropine or patching? Would you still follow up every 6 to 8 weeks and then do the same thing?
In theory, yes. Now, I will say, the reason I say in theory is because that's what the papers recommend. It's every 6 to 8 weeks. Since we have a large pediatric patient base and some of our parents that we have worked with are not as comfortable with atropine, for example, I may choose to follow them up a little bit sooner just to make sure there's no adverse reactions or difficulty with drop installation or some other type of troubleshooting I would want to work with sooner.
Yeah. Okay. And so how do you know when to stop the treatment? Like, what's the deciding factor, or when do you start tapering the treatment?
Yes, so these are patients you're going to be seeing very frequently, almost like your glaucoma patients that you're seeing every handful of months. These patients you're seeing every 6 to 8 weeks, and you're going to keep going until the VA plateaus.
Yeah.
So once the VA plateaus, and hopefully it plateaus at 2020, then you can slowly start to taper. If the VA plateaus and no improvement, then you can choose to increase the patching. So what the studies recommend is if you started with 2 hours, you go up to 6 hours, which is a lot.
Yeah.
As an aside, I will say when I have recommended that, very, very few of my patients are actually compliant.
Yeah.
It's just impractical for school age kids. They just won't do it. But nevertheless, the research says you up it to 6 hours and another percentage of patients will improve. Once you're for sure got a plateau there, then you start to taper. And I like how you said taper rather than discontinue, because that's also what the research shows. If you discontinue abruptly, the chances of the VA regressing or rebounding back to where it was are much higher. But if you taper, kind of like a steroid, I guess, if you taper, then the chances of the VA staying where it is post-treatment is much higher.
As you were talking about, compliance with wearing glasses and patching can at times be really difficult, right?
Yeah.
So educate the patients and parents on the importance of following a treatment protocol, and how do you deal with non-compliance?
Oh, it is so hard. And again, as an aside, the hardest patients that I have, the most stubborn ones, are the anisometropic hyperopes, right? It's those people that are like plano in one eye and like +3 in the other, because they really don't see a benefit of having their glasses on or off. And then once you patch them, you're reducing the vision even for them during those couple hours, so they can't play their video games or see the things they want to see. And so those are the patients that tend to want to peak. Unfortunately, compliance for patching tends not to be very good. So a lot of it's parent education. A lot of it is saying, if you invest the time now, invest the energy now, the chances that the vision will get better are much higher. For some of my older patients where it's going to be harder, I usually dangle the driving thing in front of them, saying like, well, if you want to be able to pass the DMV test without any issue, and at least here in California, you need 20/40 better in each eye. And so a lot of times that'll be our goal. Sometimes if they're sports players, we'll talk about stereo, because that does tend to be reduced as well. After that, it gets really hard. It's with classical patching or atropine, it's really hard to motivate those patients. That is where some of the newer treatments can be helpful, because they utilize things like video games and some things that are more interest driven,
You did just briefly mention the newer treatments that are emerging for amblyopia. So for some people who are not following up with the literature right now, can you actually explain that a little bit more?
Oh, yeah, for sure. So for years and years, patching and atropine, and then a third one, which is the Bangeter filter, just a frosted occluder. That was the mainstay of amblyopia treatment. And I think we're really seeing that landscape start to change in these upcoming years. There's this concept called perceptual learning that is actually a term coined from psychology. And it has to do with learning, teaching the brain how to think a little bit better, for lack of a better term. And since amblyopia is known as a cortical issue, and it really has more to do with teaching the eyes to recognize how each of the eyes works and work together a little bit better, some of those concepts started to be used for amblyopia treatment. The way to do that is they started to change video games to kind of gamify it and teach the eyes to work together a little bit better. It's like really fancy anti-suppression activities. So all of these activities have to do with targeting suppression, which is a key issue with patients with amblyopia. Some of them use virtual reality, like the Oculus Rift headset. Vivid Vision is one of the big companies that does that. And one eye sees one image, the other eye sees a similar image, but the resolution might be a little bit better, a little bit worse, contrast might be a little bit different, to try to teach the brain how to use both eyes together a little bit better. A lot of the literature that's come out of UC Berkeley and many other areas has shown that this is equally as effective, if not more effective, at improving visual acuity. And because it targets the binocular vision, it anti-suppresses, stereo tends to be improved as well. It's actually shown good success, if not better, in all types of amblyopia as well.
Mm-hmm.
So I'm guessing this is more like an in-office treatment only, right?
It started off in office,
Okay.
and now Vivid Vision, that the company that is probably the best known for their virtual reality things,
Uh-huh.
I think they have some home
Home.
versions as
So
well.
like they have the headsets. Okay.
Right. So the patient doesn't need to get the headset.
Headsets.
Uh,
Okay.
yeah. So one of the reasons why I don't often bring it up as a private practice issue is because there's a cost.
Yes.
Right. It's like this is not going to be that accessible for every single patient. There are some mobile device apps that also use red green. That can be helpful. None of these are research based. They're just kind of borrowing off of, or piggybacking, I guess, off of concepts and research right now. Those are a little more cost effective, but hard to say how effective they are, you know?
Okay.
So like perceptual learning, I feel like is, in vision therapy, we incorporate that. So we do vision therapy on amblyopic patients as well. People should know that there's an option to do multiple of those treatments at the same time too. Like we have some patients that we worked on together who were still doing their 2 hours of patching a day, but then they were also enrolled in vision therapy. So they're kind of, doing both at the same time to just get the maximal effect.
Totally. And actually, one of the things that, as you were talking, reminded me, this concept of perceptual learning and anti-suppression stuff, it's touted in literature as being new, but it's things we learned in school. It's like you learned about vision therapy, you know that it exists. Optometrists have been doing it for a long time. So it's almost like the research is just starting to almost frame it in a different way. To see that it can also be helpful for amblyopia, even though ODs have been doing this for a really, really long time.
To make it more appealing to everyone now.
Maybe freshen it up a little bit. I don't know.
Yeah. So for primary care optometrists, I know we kind of talked about this a little bit at the beginning of the conversation, but what are the success rates for treating amblyopia in teenagers and adults?
So it's a really good question. I don't have hard percentages to draw you to. The pediatric studies go as high as age 17. And what they found was that, at least in the cohort of ages 7 to 17, it's not as effective as before that age 7, but it's still effective. What I don't have, however, is people older than that.
Okay.
You have to start looking at some of the perceptual learning research papers and the video game research papers, and to find even subjects that are older than age 17. So they're not randomized clinical trials. People are still recruiting for those, but I don't have a percentage for you that I would feel comfortable, quoting, and therefore quoting like a patient, for example.
Okay. I think our conversation might just transition from amblyopia at this point into prescribing for hyperopes, because sometimes that goes hand in hand, right? You always, we were taught in school to always kind of push plus as much as we can. But there are obviously certain situations that come up where we don't know what's the best way to prescribe. And so, like for a specific example, if a child has no strabismus, but they have some moderate high hyperopia, how would you go about giving them their refractive error, especially after emmetropization has been completed? Like, is it safe to assume that we can maybe undercorrect, or how would we kind of go about that?
It's a good question. And I know, Dr. Bilku, I think you've probably come across this many, many times in your residency.
I feel
as
weird
well.
being the one to ask.
I mean, as I'm sure I'm preaching to the choir here, where there's not really a set standard when it comes to prescribing for hyperopia. We actually give a short lecture in the summer to our new third years on this, and there's a couple papers I usually draw from. One is authored by Dr. Sue Cotter. I think it was from maybe 4 or 5 years ago. And it talks about prescribing for hyperopia, for childhood hyperopia. And then there's another one, I think by, I forgot the first name. Leet is the last name, Leat. And that one is also from a number of years ago. I'm sure you can understand that prescribing philosophies are not a sexy topic to publish on all the time. But those both give pretty good guidance. And the binocular vision clinic and my training, we're taught to take a lot of things into account. So it's not just the refractive error, it's not just the VAs, it's also the ocular posture, so your cover test. It's also the accommodative status, like Dr. Bilku was mentioning. It's also the vergences. There's so many things. That said, if in light of normal accommodation, normal ocular posture, normal vergences, and just high hyperopia, I think you'd be safe cutting up to about +3. But 3 diopters, at least that's what I was taught. That's what I've seen in papers. That's kind of your hard cutoff.
From cutting back from the cyclo, correct?
Oh, I'm sorry. Yes, cutting back from the cycloplegic.
Yeah.
Now there is a separate argument. You can say, well, do I have to cyclo them versus do a tropicamide? And I think at least for young children, they feel that 1% cyclo is the best way to go.
Yeah.
Kind of like going back to that topic, as you said, like everyone has your own method of prescribing plus for young children. What's your general like rule of thumb of how much you're going to prescribe? Like I'm talking about like kids from like 1 to 7.
So especially in the early ages, we'll say before they enter school, I tend to take very much of a wait and see approach, again, because I'm looking to see how much of emmetropization may still occur.
Okay.
And they're not really in school yet, so the visual demands are not as high.
Yep.
So unless there's a strabismus that I am worried about, or the binocular function, I will, up to maybe about +3, I'll tend to wait and see.
Wait, okay.
Yeah, I've seen optometrists, wait a little bit on higher, so like a +4, a +5. I think then I start to get a little nervous because I want to make sure that there's no amblyopia that may possibly, occur. So I also want to make sure I'm not missing like, an esotrope.
Yeah.
After that, Dr. Bilku can probably attest, I usually try to push as much plus as I can. I think it's my background. So
just like the moment they start school, like then you want to push the plus. Okay.
Also because what kids can adapt so easily to anything you put in front of them, especially with even SIL, because a lot of people, I hear sometimes that they're nervous to give children a higher SIL that they have, but honestly, they adapt pretty well to whatever you prescribe them.
Yeah, no, they really do. And I do want to echo that, because I think sometimes I see, some of my recent grads or some other private practitioners to be a little nervous on prescribing a little heavy. So they'll like back off, either, it might be on the SIL, it might be on the plus. Sometimes it's prism. They're like, I see a trope. I only want to give 1 prism diopter. Like, I don't know if one's going to do what you want it to do, So I would encourage, I would encourage you not to, prescribe enough you feel that will make a difference.
So kind of transitioning into more random questions. What are your thoughts on emphasizing full-time glasses wear with or without prism in a patient that already has an established constant strabismus?
Sure. So a constant strabismus, meaning that they don't really have any binocular vision. And so you're really just correcting, I guess, the refractive error. Am I understanding that right?
Yeah.
So some people feel that glasses are good for protection because the eye that's the constant trope usually has some measure of amblyopia. Their stereopsis is usually down. And so because of that, sometimes their hand-eye coordination may be affected, their tracking may be affected. There's some other, I guess, motor skills that may be affected kind of as a secondary measure. So some people will feel that glasses are definitely necessary. I'm fine with that. I think that's okay. I will say that it probably does not make that much of a difference to the troping eye. They're likely suppressing that eye. Not that it sees nothing. I mean, they still get field out of that eye, but it's certainly not the eye they're relying on the most.
Okay.
I don't know, Dr. Bill, could you want to comment on that?
Actually, yeah, I think I was going to add another scenario to that, which would be a good one to bring up. So adding on to what Deepan's saying, so if you have a patient that's a constant strab and you're giving them a full-time RX, would you consider giving them prism? Because, if they're suppressing, are we giving them prism to gain fusion, or are we giving them prism just for cosmesis? How would you kind of approach that situation?
Sure. So prism is tricky when you're dealing with someone who's a constant trope and has zero. So when we say constant trope, just to clarify, we mean someone that has zero binocularity. Like no matter what you do, no matter what type of BV testing you do, you're like, they're suppressing that eye everywhere. So in that case, when you are prescribing prism, the prism's not really going to create BV where there is none.
Okay.
So then what is the prism really for? It could be for cosmesis. So you could consider some prism to help kind of move the images so the eye doesn't look maybe as exotropic. It could be because you want to shift the image in a certain direction for whatever reason, maybe just for patient comfort. But you kind of get the idea. It's not really to help the vision. It's more for some of these other external factors.
Yeah.
Okay. So if you have a patient, like a child, and there's like a conflict between controlling your binocular vision issues or providing clear vision. So like, for example, like they're like a low hyperope and they also have an intermittent exotropia, but their accommodation is poor. So
Mhm.
do you want to give them less plus to control the exotropia, or do you want to give them the full plus to help with accommodation?
Yeah, that's a hard one. That's a hard
Yeah.
one because really, it's basically your verges and accommodative system are at odds with each other.
Mhm.
So in that case, some supplemental information that might be helpful to guide you would be like an ACA,
Okay.
because then you can help figure out like, well, maybe the ACA is really low. So not correcting the hyperopia is probably not going to get me very far. Maybe I need to supplement with Prism. It helps give you a better idea of what effect the prescription or lack of prescription would have on the posture. But that's where, at least very generally speaking, I would start looking at things like Prism and
Mhm.
add, whether it's a minus add or a plus add, to help work with the prescription so that I could find a happy medium.
Yeah.
Okay.
That's a good question. I feel like because a lot of kids that I've seen usually will be like exophoria and
Mhm.
then they have accommodative insufficiency. And you're like, basically me. I was like,
Oh, yeah.
I do. I feel like personally in that situation, I would want to give an ad for their accommodation or at least push a little bit more of that plus for near work.
Mhm.
And I'd probably, depends on how high their exophoria is and also what Dr. Lee said on what their ACA is. I'd probably show them a little bit of Prism for near as well because it's never wrong to give both. It always depends on how comfortable the patient is going to be wearing that prescription. And like Dr. Lee mentioned, is that extra Prism or that extra plus going to do what you want it to do at the end of the day?
Do you have Prism in your glasses, Emmett?
Yeah, I do.
You do, right? Okay.
So for all of our listeners that are interested in my eyes, nobody, but I'm like a 12 exophoria at distance and 25 at near. And then with LASIK, I'm a low hyperope. So I do use a +1 readers with a little bit of that astigmatism. And then I also have about 6 base in total in my reading glasses. So I have both. And I love that because if I just look through plus, I'd be done. Both my eyes would be out here.
Yeah.
So I need both and it's pretty comfortable. But for kids, it's hard to trial things with kids because they're fine with everything. So I would go with your gut instinct once you've done the measurements and think, if I give this kid like another +1, maybe I'll throw in a little bit of base in and see what it does. Trial it in office, repeat cover test and see what it does, and then just give it to them.
Yeah, I would also agree that a kid's subjective response you might not need to take with a grain of salt, because sometimes they say they don't like it, and it's actually because your trial frame is too heavy,
Yes.
or there's just like some other external factor they don't like, and they're saying they don't like it not because of what you did, but because of something else. Maybe maybe they don't like your shoes or something, and they're like,
Yeah.
I don't want anything you give me.
So for this next question, I guess I'll throw it out to Dr. Lee and Dr. Bilku. So in your guys' opinion, what are some resources that can be used to keep up to date with the latest amblyopia treatment and when to appropriately prescribe for children?
That is a hard one because unless Dr. Bilku, maybe you're more up to date than I am, but I do not know of any good centralized area for clinicians when it comes to amblyopia. I struggle because you're not the first person to ask me that question either. When I think of where I go to look for the most recent information, I'm in academia, so it's oftentimes papers or, publications or different types of meetings. But I can't really think of a good centralized area that's good up to date. I don't know, Dr. Bilku, do you know anything special that I should learn about?
And no, honestly, I feel the exact same way as you do. And in my opinion, as a new grad, I'm using my residency as the way to get the new and latest information, which is why I wanted to be in this residency program. But I think I would recommend to all the optometrists out there that want to look for information. Again, I haven't found a centralized area, but I feel like asking anyone that's in academia will know at least maybe a little bit more of the latest information than someone who's not in academia.
Yeah. Actually, I should mention that PDIG, on their website, they have a list of all of their publications, and they're all available for free download.
I think it would be nice for you to give like a very quick, short summary of your step-by-step process for amblyopia then. So if a child comes in with amblyopia, what's your step-by-step thought process for treating it?
See, let's say that I'm seeing a new patient for amblyopia, and we go through the exam and we say, yes, for sure, this is amblyopia. And just for argument's sake, we'll say that it's unilateral amblyopia. So step one will be I give glasses, then I'll see him back in 6 to 8 weeks, measure VAs and a few other things again. If the VAs stay the same, then at that point, I would likely start patching or atropine. I usually give my patients the choice. They almost always pick patching. Most of the studies say, regardless of the VA and the depth of the amblyopia, you're going to start with a couple hours. So 2 hours a day with some near activity if you can. See them back again in 6 to 8 weeks, measure everything again. Let's say at this point we get an improvement about a line, which is typically expected. Repeat, rinse and repeat for another 6 to 8 weeks. And now let's say you're on your third or fourth visit and the VA has plateaued. So at that point, I would say, okay, let's try to up this to 6 hours if we can. Usually at that point, if the VA of the amblyopic eye is within a couple lines of the good eye, I will start to offer vision therapy as well. You'll see practitioners offer VT maybe a little bit earlier. At least in my experience, I find that I need to help the VA get a little bit better before the VT becomes very effective. So I usually wait until it's a couple line difference, but you don't have to. So at that point, usually now I'm seeing them more on a weekly basis and doing in-office VT. And by then, most of my patients I've had actually luckily have gotten to about 20/20. And then at that point, then start to taper, see him back in another 6 to 8 weeks, and then slowly start to drag out, cut down the patching, see him, I'm trying to get them back onto like an annual routine.
If only every patient was that perfect.
I know. Yeah. What I'm leaving out in between there is I didn't patch. I lost the patch. I lost my glasses. Yeah. I hate patching. I hate you. Like there's all of that in there.
Actually, I think I do want to ask, have you treated any adults for amblyopia?
The last one I can think of was a couple years ago. I'm actually not going to talk about her. The other one I will talk about is actually one of my first. So she actually started off as an anisometropic hyperope. She was 60. And, one of the things she said to me in the beginning was, before my parents passed, one of the things that I wanted to do to honor them was to get back into amblyopia treatment after all those years when I was a kid of just not patching. And she's like 60 at this point, right? She's like, is it too late? I kind of just want to try. I was like, oh, sure. What do we have to lose? We started patching, and at that point, this was maybe about 7 or 8 years ago. We're like, well, why don't we just also start VT at the same time? Because she was 20/30 in the amblyopic eye, 20/20 in the good eye. And it's like, what do we have to lose? Might as well. I mean, I'm not going to lie. It took a long time. She was in VT for a couple years. But within that time, we saw her suppression really slowly start to go away. And she improved to 20/20 minus, actually, in the amblyopic eye.
Oh.
Last I checked, she's not doing any VT anymore. She's not doing any patching anymore. It's now been 3 or 4 years since she discontinued everything. I still see her for annuals, and her VA has stayed. Like, it's held.
Mm-hmm.
And this was even before we had more papers to look at subject data. So she was, really inspiring.
I was going to say, I feel like what we should really point out and highlight from that story is that it took a long time, even though it was successful. But with adult patients, it's not that we can't treat amblyopia, but you have to warn the patient and let them know that there could be success, but we have to be patient. Like, right. It's a long time, like years, not just months.
Now, setting the correct expectations, I guess for patients of all ages, is really important.
I mean, I think you killed like all the questions.
Yeah.
Really quickly.
Yeah, no, it was great. I think I feel a lot more confident now about treating kids, and because a lot of these questions I was like, I really don't know what to do. So I'm really glad that we had this session.
Oh, for sure. Well, thank you. No, thank you. Yeah, I tend to talk really fast. Sorry.
Yeah, thank you so much for sharing your time.
You're very welcome. Anytime.
Thank you to everyone for listening to Four Eyes. If you enjoyed this episode, please be sure to subscribe and leave us a rating to give us feedback on how we're doing. You can also check us out on Instagram at Four Eyes Optom for more content. Look out for new episodes every Wednesday. So until then, stay tuned.